Welcome to the lase physician training video. After watching this tape, you should have a good understanding of the lase procedure. Review the package insert for a complete set of instructions. Lase endoscopic discectomy permits physicians to offer definitive treatment to patients suffering from radicular symptoms due to a contained herniated or bulging lumbar disc. These patients might otherwise undergo open surgery or be managed with temporizing treatment. Lase offers the advantages of minimally invasive therapy, including local anesthesia, limited length of stay, and minimal post-procedure pain. Most patients are discharged several hours after the procedure. Many experience significant pain relief during the procedure or shortly after, and the majority of patients who respond do so within 1 week. The long-term success rate is approximately 85%. Compared to open surgery on contained discs, lase offers a higher success rate and neither damages the posterior spinal elements nor jeopardizes the opportunity for subsequent spinal surgery. Lase endoscopic discectomy is a procedure for treating contained lumbar discs. It is not indicated for free fragments, extrusions, or for patients with significant bony compression. In this video, we will introduce the lase kit components and show you how to set up for and complete a lase procedure. First, let's identify all the items in the lase kit. This is the lase endoscope. The lase endoscope is actively deflectable and it contains a built-in laser fiber. It has 4 connections: image, illumination, irrigation, and laser. The image connection provides a video picture. The illumination connection provides light to the endoscope. The irrigation line provides saline solution for cooling. The laser fiber is connected to a holmium YAG laser. 2 lase kit models are available. One has a Coherent brand laser fiber connector, and the other has a Trimodine brand laser fiber connector. Using this knob, you can position the laser fiber from 1 to 6 millimeters from the endoscope's distal end. Let's take a brief look at connecting the lase kit to the endoscopy tower. You can connect lase to almost any endoscopy tower if you use these adapters. They are a Claris light cable and a Claris endoscope coupler. Choosing which model of each to use is beyond the scope of this tape, but it isn't complicated. Attach the image connector to the endoscopy tower's light cable this way. The image connector is simple too. Align the pins on the lase image connector, push, twist clockwise, and it's on. Tug to test that it's securely attached. If you wish, rotate the image connector to orient the image. Here's how you focus the image. This technique requires only 1 person and 2 hands. Place the distal end of the endoscope under a sterile drape. Grasp the endoscope coupler distally with 1 hand and hold the focusing ring with the other hand. Turn until the image is smaller. Then look at the perimeter of the image and make this edge as sharp as possible. If it's sharp, you'll find that the image is perfectly focused. The lase endoscope is placed into the disc through a working channel. Identify the working channel by its green dot. A triangular skin stop helps secure the working channel against the patient's skin. The working channel has an aspiration port for removing the saline irrigant. You can loosen or tighten the working channel's grip on the endoscope shaft by turning a compression fitting. Straight and curved working channels are available. The curved working channel is sometimes required for the L5S1 disc. The dilator fits inside the working channel and makes the working channel's tip less traumatic. You will use the lase kit's trephine to cut through the annulus. Identify the trephine by its red dot. The lase kit contains a flexible guide needle. This is the first kit component to enter the patient's body. You will pass the dilator working channel pair over the guide needle. The lase kit contains 4 additional items: a scalpel, a ruler, a stylet, and a pen. The stylet is packaged inside the trephine. You can use it as a sterile pointer or to push disc fragments blocking the working channel out of the way. Now that we've introduced the components of the kit, let's see how they're used clinically. Lase endoscopic discectomy can be performed with a patient in either a lateral decubitus or a prone position. This patient is prone. Prep and drape the patient. Hold the lase kit stylet in one hand. Use fluoro to find the entry point and anesthetize the entry point and the track using a syringe held in the other hand. To introduce the kit's guide needle into the disc, put the C-arm in an oblique view, as for discography. Remove the needle's protective cap and advance the needle to the center of the nucleus. You may need to use your other hand to keep the needle's proximal end bent out of the way of the C-arm head. Verify your position with AP and or lateral fluoroscopy. There are many theories about which side of the patient to enter. Some physicians enter the ipsilateral side, others choose the contralateral side, and still others choose either the left or the right side based on the layout of their procedure room. All strategies seem to be equally successful. Next, you should use the kit scalpel to make a stab wound by the guide needle, so the working channel and the dilator can pass through the skin and fascia easily. Lock the working channel and the dilator together and pass them over the guide needle. Advance them to the annulus. Check with AP and lateral fluoro. Your goal is to place the distal end of the working channel into the nucleus. Here's how. Remove the dilator from the working channel. Insert the trephine. Score the annulus with the trephine, then remove the trephine. Reinsert the dilator. Lock it onto the working channel's hub. Advance both the working channel and the dilator into the nucleus. Place a 4x4 between the skin and the skin stop and tighten the skin stop. Remove the dilator, attach the aspiration tubing, and you're ready to insert the lase endoscope. Connecting the irrigation is also easy. One end goes to the lase endoscope's irrigation line, and the other goes to a